Our last speakers are Katherine Grady and Linda Savas, who are going to talk about their project Care Call.
My name's Linda Savas and I work for Greater Manchester QiC, and QiC stands for Collaboration in Leadership for Applied Health Research and Care, and it's a collaboration between university and local trusts. It has two broad aims. The first aim is to conduct high quality healthcare research, and the second aim is to ensure this knowledge is translated into practice. And the project we're discussing today with my colleague Katherine Grady won the Quality in Care Best Type 2 Diabetes Initiative in 2011, and it was a collaboration between the Greater Manchester QiC and Salford Diabetes team. And together we adapted their existing telephone-based care call service and we offered it to patients with impaired glucose tolerance. And why did we do this? Well, we all know there's an increasing prevalence of diabetes, and it's predicted by 2025, which is only 10 years away now, there's going to be 5 million people with diabetes. 10% of the NHS budget is spent on diabetes care, and one medical journal actually went as far to say that these costs threaten to bankrupt the NHS in the next generation. And approximately 50% of people with impaired glucose tolerance will develop type 2 diabetes without any medical or lifestyle intervention in 5 to 10 years. And this is also accompanied by an increased cardiovascular disease risk. Our lifestyle today doesn't help this because we're often inactive and often overweight, which increases our risks. And this was particularly relevant to Salford because over half of the 220,000 population, they were recorded as overweight or obese. There is strong evidence out there to suggest that lifestyle interventions can prevent and delay diabetes. And again in Salford, there's 7,000 people diagnosed with impaired glucose tolerance, which has the potential to increase our diabetes registers by 3,500. So we got together, the Greater Manchester QiC and the diabetes team, and we met the senior management and we got all the key stakeholders together and we developed our pathway, which you can see there. We engaged the diabetes group and got clinical support, and we also had user representation right from the very start. The pathway was simple. We involved 7 GP practices. They all referred the patients, and we had 55 patients enrolled. The diagnosis of impaired glucose tolerance was made at the GP practice, and once it was made, they were then referred to our care call service, along with the BMI results, weight results, the blood results, and we also did a FINDRIS score. When care call received the referral, a health advisor contacted the patient to tell them about care call, and they then sent them an information pack and signed them up to the service. The information pack sent to the patient included their blood results, and this was a key thing. A first appointment was made, and this was given by a healthcare professional. And the healthcare professional phoned the patient and discussed those blood results and what impaired glucose tolerance actually meant. And this enabled the patient then to make a goal to see where they wanted to be in 6 months' time and change the lifestyle. They also made a smaller goal that was achievable in a month that ultimately led to the 6-month goal. And from that point onwards, a health advisor that was labelled with that patient and stayed with the patient for 6 months then took over the care. So after a month, the health advisor would contact the patient and they would deliver education through a series of electronic scripts that were all developed and maintained by the specialist diabetes team. If the patient required any information, that information was sent and it was tailored to the individual patient, and it allowed a little resource of information to build up over time. After 6 months, that's when the patient was discharged from the service. We then went on to evaluate the service, and our evaluation included clinical outcomes, it included feedback from the service users themselves, also information from the healthcare professionals, and we also did a cost-benefit analysis. The evaluation form was fed back to the diabetes strategy group and the trust boards, and our results were statistically significant. They all acknowledged the results and the outcomes and were very pleased with them, but they wanted us to follow it up in 12 months just to see if these results could be ascertained, which they were, and Katherine will go into shortly. We also received further funding to roll this service out to a phase 2, and we rolled out across the whole of Salford to every GP. We did include some changes in phase 2, which were suggested by the service users, and again, Katherine will go over that. So I'll just now introduce Katherine Grady to you to continue.
So in terms of the first pilot phase, which was the 55 original participants, we looked in terms of clinical outcomes at fasting blood glucose, at weight and body mass index as well. And we looked at those at baseline, on completion of the 6-month programme, and again 1 year following discharge, because that was what people were very concerned about. People said, you know, you've got fantastic results at 6 months, but what happens when they've been without you for a year? And improvements at all 3 stages, improvements in all of those 3 outcomes, in blood glucose, weight and BMI, were all statistically significant, both at 6 and at 12 months. Across the whole group, mean weight at 6 months reduced by just under 3 kilograms, which equated to about 3% body weight compared with baseline. And this was the same a year following discharge as well. The fact, I haven't gone into details on the slide with the results, but we have put a poster out of our 6 and 18-month results in more detail for you. The fact that the results were maintained at follow-up suggests that the programme was successful in maintaining the behaviour changes longer term. The rollout phase, which was available to all of the Salford GPs to refer into and covered 207 patients, again, participants achieved very good results in that. We had statistically significant improvements in weight at 1 year. On completion of the 1 year programme, the weight loss was 4.7% body weight across the whole group. The improvements in fasting blood glucose were not statistically significant. However, on completion of the programme, 46% of people had reduced their fasting blood glucose back to within normal ranges. And we had really good feedback from both the patients who took part in the programme. We held a series of focus groups and questionnaires as well. And the practices who took part also gave us very positive feedback as well. However, we do acknowledge that these are still relatively small numbers on the grand scale of things. And so the results should be interpreted with a degree of caution. Oh, have I whipped through there? Okay, sorry. A cost-benefit analysis has been undertaken by Professor Bowden at Manchester Business School, and the cost of providing the service per patient was estimated about £136 per person, and that includes the overheads as well. This graph was put together to show the potential cost savings really for Salford's estimated 7,000 impaired glucose population, and it assumes a linear rate of progression over a 10-year period. So the red line shows what will happen if we do absolutely nothing at all and carry on the way we are. Half the population will develop type 2 diabetes. The yellow line shows the estimated reduction that could be achieved if a programme like this was implemented in Salford. And it also incorporates the cost of delivering the service as well. And the difference between those 2 lines, also represented by the green bars here, shows the payback on investments and the potential savings that could be achieved. So there are significant savings that can be made. In terms of recommendations for success, our recommendations would really be to identify the key people early, to get them on board. That includes commissioners, and to keep them involved throughout. Throughout the initial pilot phase and also our rollout phase, we endeavoured to share our successes and learning as widely as we possibly could. For example, via trust partner organisations such as the Manchester Academic Health Science Centre, the Global Network for Diabetes Prevention, and publication of journal articles. However, winning the Quality and Care Award really paved the way for our success and really gave our project really some, it really raised awareness of it. Following on from that, we received a commendation at the HSJ Awards the following year, and we've been invited to speak at various conferences, including the King's Fund International Congress of Telehealth and Telecare. We were featured on BBC News, and we were absolutely delighted when NICE published their PH38 guidance in 2012 around prevention of diabetes, that they cited our project as an example of see this guidance in practice. Salford now has a commissioned service for people with impaired glucose, and that includes our recommendations of a district-wide registration and recall system for people with impaired glucose, as well as a standard approach to GP coding across the district. In terms of where we are now and our next steps, Salford Royal, the CCG, North West Health and Hitachi have entered into a collaboration to look at whether technology can now enhance the pathway that was already in existence for our project, and to complement that. We've completed a proof of concept phase with Hitachi, and we're shortly about to start work on what we're calling an IGR phase 3 project. In addition to this work, Salford City Council, the CCG, Salford Royal are all also working together on an integrated care programme, and that will improve the way that over 65s access healthcare in Salford, health and social care services. And the aim of that is to provide more care at home, reduce hospital admissions, and ultimately help people to have healthier lives. And part of those plans include the development of a contact centre which will adapt this health coaching model that we had here. So our work from the Impaired Glucose Project has and will continue to inform this work. And last but by no means least, Diabetes UK also heard about the work we were doing in Salford around diabetes prevention, and we're currently in the early phases of discussions with them, working together to develop a Healthy City initiative, which will include a wide range of health and social care partners. Thank you very much for your attention. All our reports are available for download on the Clark website.